So we have a young woman, un peu vers moi l'écran s'il te plaît, a young woman presenting with bladder, rectal, vaginal and sigmoid colon nodules, endometriosis nodules. Very symptomatic because she has digestive and urinary complaints as well as a pregnancy intention. Insufflation. So we propose her management, full management, complete management of the endometriosis, including a resection, excision of the bladder nodule, photo, encore une, attendez, hop, oui, encore une, et traîne s'il vous plaît. Also the excision of the rectal endometriosis and probably a separate resection, segmental resection of segmental resection of the sigmoid colon infiltration. Photo. It's a very small ovary on the left side. It would be better to release it because it's quite inaccessible to function, IVF function. Here we have photo encore. Here we have the bladder endometriosis, bistouri. Quoi sur le petit, sur le grand? So we'll insert 3 trocars, 5 mm trocar. Okay. We also will have a look, once we insert the trocar, we'll have a look on the cecum to see if we have any lesions on the cecum and the sigmoid, the appendix or the ileon, because more and more frequently we find this type of lesions. And here we have the rectal endometriosis, and where is the sigmoid colon endometriosis? And here, yes. Let me see if you photo. Thanks. So we have a sigmoid colon endometriosis, rectal endometriosis, and they are enough far each over to be able to remove them by two separate procedures. So here we have a small lesion. We have to remove it because this is the unique fallopian tube which is feasible, which is functional. Hold it, please. Oui, on va faire un test au bleu. And don't move, Jamil, I'm working. So you start by removing this and this lesion, and by carrying out a tubal patency test. Okay. Endometriosis. Okay. Go on, my friend. Yeah, it works. Okay, push, push, push. Yeah, but you have to push. Okay. No, it is. No need, because it is normal. Photo. Okay, go on. Mm. Yeah, it works. It works. Okay, very well. Now, let's go on the bladder. So, retroverse, ultracision. No, I did it. I've already did it, yeah. Non, non, mais t'as fait. Non, mais il a raison, parce que parfois j'oublie. Allez, photo. Thanks. So. And why did you say that you're going with March in Budapest? Yeah, yeah, yeah. Yeah. In Tameshwar? Yash. Okay. Mm. Yeah. But it takes 1 day to do this. Yeah. 2 days. Yeah, you will come back with hair like Jimi Hendrix. You do not have to change too much, because it may be very surprising for Anna. She changed the guy. You knock on the door and your daughter is said, "Who are you looking for, sir?"
The hairy man.
So he sent you that you need the special reason you Canada?
Yeah.
Okay.
And the 3 point very very nice.
Okay, so I opened the vesicovaginal space in order to mobilize the bladder, and now we have to continue to dissect here, but taking care not to injury the ureter, which is not which not becomes not very far. Okay, very well. So I think that the limit should be here. So please be ready to close the bladder, to close the catheter.
Do you think that we have to open it? Or
Yes, of course, I think. This looks very infiltrated.
Maybe you. Oh, you open it already.
Yes, here into the bladder,
Nice.
but you're far from the ureters. If you want to see the ureter, it should be here. I think it should be here.
Yes. Yes. It's
Here, okay. Very well. Veloc. So we finish to resect the bladder nodule, and we'll close the bladder by a continuous running suture using Veloc, and we'll keep the bladder catheter for 1 week in order to let photo to let the time to the bladder to heal. Now, to reduce the tension on the bladder, it is useful to open the radius space like this, not as far as we carried out a birch, but anyway, you have to reduce the tension like this. Come here. Okay. It will be okay. Now we'll insert. Hold it, please. We'll insert the thread to carry out the suture.
Actually, tomorrow you have class.
Yeah, I have class every day. Intensive class.
It's very intensive.
Yesterday I was there at this.
And you finish at 1:30.
Always the same at 1, but it's like 10 minutes walking.
So you do robot.
The robot. Okay, hold like this.
I just put on
Yes.
The robot is afternoon, no?
No, it's in the morning. Beginning with tomorrow, the robots will systematically be in the
So
morning.
the first case will be
Yeah, the first case will be the robot.
at what time?
But 8 o'clock, as usual.
So it's good I can come 8:30 because robot preparing you don't need to.
Yes, you can.
It takes 1 hour preparing, yeah?
You can. No, it's much less because the preparing starts the day before. That's why we moved. It is better to do the first surgery with robot because everything will be ready. But 8:30 it works.
I'll be preparing by the position of the patient and
Yeah. It is not as long as in the afternoon. Okay. Now show me where is the get down, get back when I get back. No, get back with the endoscope, Marchie.
But I can hold this.
Yeah, you can hold. Okay. So ask me the questions about the study with fistula. Because you said that you have 2 or 3 questions about.
No, after reading, no, it was before.
Oh, okay.
Before, but you didn't know. I didn't know that. In which paper you are gonna publish that?
I submitted in Human Reproduction. It is in lecture, in review. Okay.
How is the patient from Friday?
Very well. Patients of January or very well.
Just in December, they were, but
December patients were more or less, but okay, hold it.
what do you think? What is
I think this is the statistics. So we have 3% of fistulas a year. So if you have 4 or 5 months without fistula, you may expect to have 1 month with 5 fistula. Okay. So we should have 10, statistically we have 10 fistula a year. And as we had no one since August to December, it was expected that the monthly fistula will arrive together at the same time. Yes. And I had the same periods in 2016 in Rouen, where after a period of 8 months without fistula, we had 5 the same month, and which is interesting, and it happens here too, that there is no one technique which is complicated with fistula, but all the technique. We had one fistula after colorectal resection, one after disc excision, one after one technique. Yeah. And now I think that for 2 or 3 months, everybody will be okay.
And if you have 6% fistula, it means that next year you will not have it.
No, we have to decrease to 1% of fistula, but it is quite impossible if you take into account the high rate of low rectal endometriosis we have. Donnez-moi un fil de Vicryl. Vicryl 0. Je vais mettre un fil d'attente. I will put a second thread in order to be able to do the stitch. Non, je le mets comme ça. Pourquoi on n'a pas de... Mais il nous faut, hein, parce que pour la deuxième, on n'aura pas besoin. Pour la... Non.
For you, which is the worst complication? What do you consider as the worst possible outcome?
But the most embarrassing complication, in my opinion, is not the fistula of the rectum, but that of the ureter. The fistula of the ureter is very difficult because some of them require nephrostoma, and nephrostoma, I think, is worse than the stoma. Me, I would prefer to have a colostoma than an ileostoma.
Why?
Because nephrostoma is much more difficult. You have a pipe which is connected to a pouch, and it is not. It is difficult to live, and you have the flavor, the smell. You smell the urines. Anything you do. I have a young cousin who has cancer, ovarian cancer, and she has 2 nephrostoma and 1 colostoma, and from far the nephrostoma is more embarrassing for her. Okay.
Why?
Hmm?
Why?
Because it's much more difficult to handle.
Why does she have
Ovarian cancer.
that's operation?
Yes. It's a very sad story because je vais couper ça aussi, because it is an unbelievable story. So she was 29-year-old when she intended to get pregnant, and after a 1-year infertility, she asked me the advice. Ciseaux. Don't move, Marcie. It's okay. So she asked me the advice, and in 2009 I was in Romania, in Desh, in my town, and I carry out her laparoscopy with a colleague, a friend working there.
Why?
The laparoscopy to see why she's infertile. I found, yeah, I found some endometriosis lesions. I carried out drilling because she has polycystia, and I removed a very small millimetric lesion on the ovary, and I told to my colleague I will remove this because to make sure it is not a borderline. But me, it's what I don't remember. Honestly, I don't remember what I did. But my colleague said you remove it because you said, let's see if it's not a borderline. It should be something like this kind of lesion. And 1 month after, my colleague called me and says, you know, your cousin, actually she has a borderline because we received a histological examination. I was very surprised because I completely forgot this cut. So I said, come in Rouen in order to have a second look. Just a moment. Ça va pas, ici, il nous faut une autre. So she came in Rouen, photo, to have a second look laparoscopy. Anteverse, my friend. And from this moment, you anteverse continuously. So she came in Rouen, and I performed the laparoscopy 6 months later, and then I found a lot of lesions, and an ovarian cyst again. So I removed the ovary, and I carried out, no, just one, where there was a recurrence of the cyst. And I carried out a large excision of omentum, all the lesions. And I presented her case at the staff, at the meeting, multidisciplinary meeting, and they said it's just we have to attend her by ultrasound. Well, I did it, and 6 months later, I was back in Romania, and we carried out ultrasound, and there was a big cyst on the ovary, and he said, hold it. And I said, okay, it's a bit more severe. And there was an indication to have chemotherapy. So I said, if you have chemotherapy, it is better to have a second surgery in Romania, because the cancer center, because if you have the surgery in Rouen, you're not recommended by a Romanian doctor, you can, you know what. Okay, so she had the surgery, and then the guy had to carry out, a very good surgeon, had to carry out not only chemotherapy, but he found lesions everywhere, and this time they were not longer a borderline, but an adenocarcinoma. So he removed the ovary, he removed the uterus, he removed he performed a colorectal resection.
But it was not endometriosis.
No. Nothing. The lesions of endometriosis were just on the first surgery. And then she has chemotherapy, and she presented a recurrence 4 years later. And this time the recurrence was the second resection of the colon, and bilateral hydronephrosis, and now she's continuously under chemotherapy, since 2017. And it is almost sure that she will never remove bipolar. She will never remove neither the bilateral nephrostoma nor the colostoma. Hmm? Now she's 40, 49, yeah. But everything started when she was 30. And I said it is, however, unbelievable because you cannot imagine a more favorable situation. A patient where the diagnosis of the borderline is done incidentally when you have only one lesion of 3 millimeter, then
Maybe she should to remove everything from the first, the uterus and the ovary.
yes, but yeah, and, but you cannot do it. There were no argument to do it.
And then borderline.
The day where I carried out the surgery in Rome, there was no argument to do this.
Okay, and the cyst you remove it in Rouen is where also
Borderline, borderline. There are no cancer, but I think she has a kind of cancer where there are continuous mutations, and that's why each time he carried out, she has chemotherapy. It works a time, and then there is a recurrence. I think she has a very, very aggressive disease. Sorry? Who? Masters Allen. I don't understand. Why do you speak about Masters Allen? Masters Allen, when you have a hyperlaxity of the uterus is moving in all the sense, all the directions. Usually after the pregnancy. This is the Master Allen for me.
hypermobility.
Yes. That this is not Master Allen for me. Is peritoneal endometriosis, but I don't think it. Okay, I let it down. I don't need more than. And now let's dissect the rectum like this. Okay. So we'll dissect the rectum and we'll prepare for disc excision. Then we'll perform the segmental resection, and at the end we'll remove the rectal disc. No, there are cysts into the deep endometriosis node. It bleeds from the ovary. This is March. Eh? March is grasp. In Romania, the resident said, S, Professor S, you cannot be responsible for the bleeding. It's sure I am I.
It's from the victim.
Yes.
Yes, it's from victim.
À quel correspond
Bonne année.
Ah ben, évidemment que vous pouvez en parler, voyons. C'est quoi le joint? Quel joint? Ça? Ah ben, mais moi j'aime les... Non, j'aime les rotatifs. Pourquoi il n'aime pas les rotatifs Et pourquoi? Ouais, mais c'est un grand avantage le rotatif, regarde ça. Tu fais ta prise comme tu veux, non? Vous n'êtes pas d'accord? C'est vous? Ah oui, donc c'est vous qui vous n'aimez pas, donc du coup il n'aime pas, lui. J'ai toujours dit qu'il a peur de vous et du coup, toujours dit il a peur d'elle et du coup, il faut que je négocie directement avec elle quand je veux quelque chose. Non, moi j'aime bien ça. Et les ciseaux pareil, j'aime bien quand ça tourne. Mais pourquoi vous n'aimez pas? Tu vois, elle dit pas, quand je dis que Benjamin a peur d'elle, elle dit pas non, non. Vous dites pas non. Non, mais j'aime pas tourner la main comme ça quand c'est. Ah, tu m'étonnes. Tu m'étonnes. Et Denis, je l'ai connu quand il était interne à Rouen. Il était interne en même temps. Et vous prenez soin de Benjamin. Non, parce que j'ai besoin de lui. Non, honnêtement. Non. Ok. Ok, let it down. Je pense que la médecine a changé, les exigences des patientes ont changé, tout a changé. C'est pas pour autant que les patients se rendent compte, hein. C'est pas pour autant que les patients se rendent compte de ça. Ouais. So here we have the infiltration. Sorry?
There's also one which is a bit higher. The rectum
Where?
Sigmoid.
This is the same, and we have another one of the sigmoid colon.
I'm just not sure whether this is
Sigmoid.
Mais moi, dans la pince que je veux, que j'ai dans la main, je veux qu'il soit rotatif. Ouais. Bah, les aides vont s'adapter, hein. À condition de les laisser de temps en temps aider Benjamin. Ah mais non, mais c'est justement parce qu'il sait. C'est ça qui pose problème. Hop. Ouais. Ouais. Bah, voilà. Bah, boum. Bifle. Ouais. Okay, clean please. Clean your... Par contre, maintenant sans blague. Sans blague. Quand vous faites une chirurgie live, vous ne pouvez pas être tous les deux. Parce que l'image bouge trop. Par exemple, celle qui a été transmise à Prague, elle n'a pas été nickel parce que ça pixelisait chaque fois que ça bougeait. C'était pas notre faute, c'était leur faute. Mais du coup, quand vous gardez la caméra et en plus vous l'aidez, du coup ça bouge trop. Donc sur une chirurgie là, je pense il y a un intérêt à être plusieurs. Parce que sinon, vous faites votre travail super, mais les autres ont un petit peu du mal à suivre. Et vous en avez une fin février pour Tel Aviv. Vous savez? Il va vous le dire. Vous avez une chirurgie live pour Tel Aviv. Et là, il faut que vous preniez déjà un fer au centre des jambes, c'est sûr, pour que vous ne soyez pas obligé de... Enfin, sauf si vous suspendez... Oui, suspendez, oui, tout à fait. Oui. Mais non, mais il vous dira, mais il faut il faut lui tendre la perche, quoi, parce que sinon... Oui. Hein?
I was grabbing your finger maybe.
Non. Mais finalement, finalement, il a obtenu ce qu'elle voulait.
Warm? Yeah.
Finalement, il a obtenu ce qu'elle voulait.
Elle a obtenu la moitié de ce qu'elle voulait, mais bon.
Ah, it was harm. It's normal.
Ok, non.
Par contre, oui, avant de valider avec John et tout, oui, parce que...
I send you.
On est dans une négociation. Chacun doit laisser un petit peu, voilà. Que l'autre ait l'impression qu'il a gagné, voilà. Non. Merci à vous aussi. Vous faites quoi, un robot? Comment ça, des petits trucs? Mais là, il a dit qu'il fait plus de petits trucs. Encore des promontos? Non. Ah, bonne journée. Ouais, je cherchais un peu. Hein. Elle n'a pas l'habitude d'être cherchée. Non, je pense. Bon, au moins, on a, voilà. On a placé. Ah, ouais. Quoi? You don't feel well? Ah ben, heureusement qu'elle est partie, hein, parce que Dina, mais voilà, travaille avec Fellows, voilà. Ah, bravo. Il tombe dans les pommes. Do you want to eat, to drink something? If you want to remove your gloves to drink something, huh?
I was leaving eating. Maybe that's
Ah ben, comment on son poste de fesses? Comment ça? Quoi donc?
Pour se reposer.
Ah ben non, mais oui, mais il faut pas le donner à Ahmed, parce que là, il va dormir du début jusqu'à la fin.
Non, non, c'est pour être debout tout en étant appuyé en fait. Hein. C'est mieux.
Hein? Chacun prend pour son grade. Okay. Okay, let's continue because we are discussing about a lot of things, but excepted the surgery. Okay, I'll take it. Hein? Okay. Okay, so now we'll remove the vaginal nodule et un trocard de 10. Don't move, Marchie. What are you doing? I'm cutting the...
Do you eat, Martin? Do you eat? Yes?
You're white as a shit.
No, I'm okay.
Hmm?
No, I'm okay. Should I take it out?
Yes. Okay, very well.
You want to put your finger there?
I put my finger in order to check that everything is soft. Wonderful. Okay. Now, stitches, stitches, and stitches. Okay, show me the abdomen, please. Okay. Okay, let it down. Have to close carefully because we have two digestive tract sutures. Who sent me a message? Qui m'a envoyé un message? Ça fait bling. Ça signifie pas que c'est cuit, ça signifie qu'il y a un message. Hein? Ah.
Have you read about that professor that they say that the artificial intelligence in the radiology and in the MRIs and so
Yes.
on is better than
Yes, to
doctors?
detect, yeah. But now I'm sure that if you put a lot of information, 100,000 informations in a artificial intelligence robot, it will be better than the best surgeon. I'm sure. And I'm sure that in the future the surgery will be done by robots and the surgeon will just supervise. I think the surgery will be very amusing
It's really interesting.
this time. Yeah. But it's sure. I'm sure this is the future.
The future, nobody will find a work.
Yeah,
Yes.
that's also true.
Yes, you're right, my friend.
Many things will be done by computers. Not only medicine, everything.
More and more people on the earth, less and less work.
Cannot end up well.
Okay.
Compared to the size of the hole is not that big.
Yeah. You're right. my friend.
I think the hand of the patient is tombé.
Ah, la main de la patiente est tombée.
I'm not sure, but oui.
Ah, c'est le chauffage. Non, non, c'est le chauffage.
It's just the warming
Yeah,
device.
I said I'm not sure, but I felt something.
Okay.
Something warm.
Yeah. Like a hand.
Something warm and touchy.
Juste là aussi.
Encore deux.
Me redonne un 8 0, s'il te plaît.
Tu crois qu'elle s'est fâchée, Valérie? Ouais, Sylvie. Ok, j'espère que c'est considère pas prise comme ça. J'espère. Hein. Je crée pas de soucis à Benjamin. Qui se prenne pas un savon, Benjamin. Hein? Ouais. Vous pensez qu'elle s'est fâchée, Sylvie? Non. Parce que je voudrais pas que Benjamin se prenne un savon. Hein. D'accord, ok.
Benjamin.
Moi, quand je bossais avec elle, elle était à Saint-Og avec les urologues. Vu que les urologues discutent pas avec les infirmières circulantes,
Ouais.
normalement, c'est vrai que c'est les aides-opératoires qui
Comment ils discutent pas avec les... Pourquoi?
Ils se font avec leur orthodoxe, avec leur... Voilà.
Ah, mais tiens, je pourrais faire pareil. Hein.
Voilà, donc,
Bon, Caro, je vous dis plus rien. J'ai compris qu'à Saint-Og, les urologues ne discutent pas avec les circulantes.
et c'est vrai que moi, du coup, si vous avez pas...
Je vais faire pareil.
Et c'est vrai que...
On demandait à Caroline si elle a passé des bonnes fêtes. Bon, mais dites-lui que je me réjouis pour elle. Phil.
You don't pull it from the side?
It means it falls down. No, this is the bladder. This is the bladder.
Ah, you pull it from the side, you don't.
I forgot. Oh, come here. Fellow. Le seul problème des fellows est qu'il n'y a pas d'assurance. Hmm? Qui?
Pascal. Grande partie.
Quel
Depuis,
Pascal?
je suis invisible à ses yeux.
Quel
C'est
Pascal?
l'infirmière qu'on avait ce matin.
Ah bah bien sûr que j'ai pas là. Pourquoi il dit ça?
Parce qu'elle trouvait enfin voilà, qu'elle se sentait un peu invisible. Alors qu'elle dit, bah non,
Si, mais je lui ai dit, écran, tout ça.
elle m'a pas dit bonjour, elle m'a pas dit bonjour, et puis
J'ai pas dit
elle ne parlait
bonjour.
pas.
Comment j'ai pas dit bonjour? Oula.
Infirmier, it's the verb for nurse.
Huh?
Infirmier is the nurse. Infirmier is the nurse.
Yeah. Okay, take it, please. Oh, mais c'est dommage qu'elle pense ça.
The one who is assisting, they are also infirmier.
Yeah, we have two nodules. We have one here and one there. So we have to carry out resection. We cannot do anything else because there are two. Milan is infirmière too.
Resection from here up to there,
No, just a resection here, very short.
and there.
And there we'll do a disc excision. So we'll carry out segmental resection only on the sigmoid colon.
C'est entre infirmière et médecin.
Because it's too large. Because we have here, look, let it down. Let it down. We have here, we have there, and we have there. Yes. It is too large and too long for a resection at this level, because the higher you are, the more narrow is the sigmoid, so you cannot push a 33 millimeter device. You know, you have to use smaller and smaller circular stapler, so you cannot remove big nodules. And the other reason is that instead of large and hazardous disc excision, here it is better to carry out the small resection because the functional outcomes are not different. You're not on the low rectum. On the low rectum you do anything we can to have to perform disc excision, not a resection, because of the risk of functional outcomes. But here the risk is less.
Is there anything on the below?
No. Get back with your endoscope, please. Okay. Okay. Et pourquoi on n'a pas des petits avec chapeau? Mais on va prendre un petit, quand même. Ouais. Parce qu'elle lit pas vos protocoles. vous êtes où avec l'examen? C'est quand?
Je sais pas, l'examen, c'est un dossier à rendre.
Et c'est pour quand?
Je me suis fixé comme objectif décembre
Décembre 2020?
2020, ouais. Ouais, parce que j'avais déjà envoyé mon lycéen en 2017, donc il me reste plus. Il faut que je le fasse dans les 3 ans. Enfin, en tout cas, que je présente mon objectif. J'espère que c'est bon.
Ok.
Voilà.
Put it down. Ok. Okay, let it down.
Camera become fat on the fat tissue.
Let me see if we have. Superficial, this one. Okay. Let's say that we'll stop here with the resection. Ok, il me faut une... ok, let it down. Let me see if this works very well. Okay. We just open the peritoneum in order to be able to pull out the... Okay, on the other side. Ok, very well. Trocar de 12. So we insert the 12 millimeter trocar. Show me. Ouais. Bah, il a été opéré déjà, je pense. Ah, et après,
Puis aujourd'hui, le dernier.
ok. Donnez-moi la mouse. Ok, come here. Okay, it's okay. Now, come back on this side, on the middle, on the midline. Protect the fallopian tube. Waiting for 15 minutes. You're waiting for 15 seconds to improve the hemostasis. Yeah, I think it's not. Hold it, and you will feel it is superficial or not. Hold larger. Hold the wall. Hold larger to feel, like this. Oh, it is superficial? No, I don't feel.
There's more on the left side,
Oh, what is happened? Okay. Scissors. Pince. So let me see. Yeah. It is completely stapled. Okay, so I have to remove this. Very well. Now, leave it. Arrêtez l'enregistrement. Oh là là, ça fait un moment qu'il n'est pas venu. Okay. Hold it.
I have a girl in the French class who is
Il y a la Joanne qui est tombée.
who is Spanish and she's anesthesiologist. And
Okay.
she also has a French husband, so she's coming from Barcelona to Bordeaux to work, and she's also studying French. I told her that she's crazy to leave Barcelona.
But it depends if she has a good job in Barcelona or not.
She does. She said that she does.
So why she leaves? Why she
Because
left?
of her husband, who's French.
Oh,
Husband doctor also?
No, he's I think he's informatics or something like that. Engineer.
And in Barcelona, I think there are so many tourists that
Yeah, maybe.
they are fed up with.
Yeah, maybe.
Like this, gently.
She was telling me that there's just one public hospital in Bordeaux. It's true?
No.
No, there are several hospitals in Bordeaux.
But public one.
In Sino, there is
No,
one.
you have
University one.
Bagatelle. It's a public hospital.
Yeah, that's what she said, I think.
Okay, stop. Stop. Bagatelle is public. Hein? C'est comme les centres anticancéreux. C'est oui. Oui, ils sont exact. Mais il a une mission publique. Ouais, je sais pas. I think it's here. Yes, here. So this is not actually superficial, this touch.
Superficial, but from the side.
From the inside, German should be a politician.
Yes. Certainly. Okay. Just a moment. Non mais je ferai plus attention à Pascal. Lui faire la conversation. Que quoi? Oh. Alors là vraiment c'est pas une étiquette que je voudrais qu'on me colle. Mais après la réalité est que les gens sont plus compliants à la limite, plus intéressés, enfin comprennent plus vite. Hold it. Mais si, ouais, c'est ça. Exact. Oui. Quand il faut dire j'ai plus d'eau, tu vois, de temps en temps tu regardes. Ah. Non, je voudrais d'abord des pinces. Oui. Qui? Oui. Il faut pas dire trop fort parce que ça vous pouvez lui dire parce que c'est vous qui avez le droit de parler avec elle. Du 28. Pourquoi? Ouais. Oui, bien sûr. Non mais je suis d'accord, mais dans ces cas-là, je ne paie plus la dépense à la clinique. Oui. Ok. Qui a dit ça? Hein? Qui a dit ça?
Pascal, c'est
Ouais,
pour ça qu'elle s'est posé la question, je pense.
Phil. Ouais, mais on peut lui dire, bah oui, mais t'es jamais encore sorti, donc du coup on n'a pas pu.
Jenny lui veut quelque chose, je sais pas quoi, mais...
Vous avez appelé docteur Forestier? Ah bah super. Elle a dit, elle a fait. Ok, hold it like this. Non, non, on fait résection et discoïde. Ouais, parce qu'on a 2 lésions. Enfin, on a plusieurs. Ciseaux. Un fil de vicryl. Yes, we'll carry on. Euh, pour faire la... Pour faire... Pour le sujet, mais PDS. Hein. On fait une résection, ouais. Une résection segmentaire du côlon associée à une exérèse discoïde du rectum. Ce week-end, je peux, oui. Je préfère ce week-end parce que le week-end d'après, je vais faire l'anniversaire de Mélisande. Oui, celui-là. Mélie. De Mélie. Oui, celui-là. Ouais, ouais. Yes, sir. Un repas au restaurant. À la fin du mois, pas le dernier jeudi parce que je suis à Paris. Il a le congrès Santé Femmes. Ah. Le jeudi d'avant, c'est-à-dire le prochain. Arrêtez de filmer. Ok, my friend. On peut commencer à filmer. So, let's start by carrying out the colorectal anastomosis. So, to do this, we use a 28 circular stapler. Okay, very well. Okay, go on. So, perfect. Now, ultracision. Hold the camera, please. Oui, je vais nettoyer. Non, mais c'était en décembre, mais on peut pas lui faire en décembre parce que tout le monde est en vacances. Ah oui. Non, non, c'est au bowling. Élevé au bowling. Je vais pas être appelé pendant que... Voilà. Ok, bipolaire. Don't touch. No need. Hmm? Show you to touch? Touch, touch. Hey, touch. Come on. Okay. Hold please. Okay. Okay, put it inside. Like this. You put and then... Okay. Oui, mais on peut pas toutes sont des superficies. Ouais, vas-y. Ouais. Ouais. It's a superficial, this one. Now we... No, but this is superficial, so you cannot cut and cut and cut because you cannot cut 50 centimeter. Even between the two, there is a very small one, very superficial. No. Okay, wonderful. And now we have the second one here. Here you need a 31. Vikrin, hold this please. Hold the camera. Because I come to suture it. We put a stitch there and there. On met par ici, par latéral. No, I will take it because I have to be... to feel exactly where I put the stitch. Laquelle?
Il y en a une qui traîne en fond que tu mettrais le truc. C'est laquelle? Moi j'ai entendu les produits segmental.
Signifie que si on a encore des fistules, il faut faire une avec 4 lignes. Alors, pense. My friend, you have to just to push like this in order to. Perfect. Excellent. Anteverse marchi. Ok. Ciseaux. Laterally. Pense. On peut appeler la patiente suivante. Ok, push like this. Avance un peu. Come closer to make me see. No, I cannot see. Just a moment. Jamil. Stay like this. Make me see where is the. Okay, anteverse 4. Et outside. Ouais. Ouais. Perfect. C'est parfait. Perfect. Photo. I will cut. I will cut it. Don't fool. I will cut. We'll cut it. Go on. Where are your scissors? Come on, cut it. Don't. You should not pull. You have to cut on place in situ. Without pulling, yeah. Because maybe you will remove a stapler. Okay? Il est gros? Anteverse. Bon, c'est souple partout. Hein. Mm.
How much?
9, 8, 8.
Professor, I think here they do subtrajectomy and they fix the ovary to the.
No, I don't think. I think they are just adhesions. But they is he, is Stefan.
Yeah?
Yes. Tiens, l'ouvert.
It's suspicion and this is suspicion.
Vous pouvez réduire le train, mettez à plat la patiente. Complètement à plat. Okay, go on. Perfect. What? Ah, ura. I understood Ola. Okay, very well. Ok, on peut arrêter de filmer.